Welcome to this presentation. My name is Ole Wiese and I serve Philips in the Nordic countries, working out of Copenhagen in Denmark. Today I have the honor of presenting to you Dr. Julien Savatovsky. He will explain to you his initial experience with Quant, quantitative imaging based on SyntheticMR, and also based on the power that AI-based acceleration can give you. So first of all, welcome that you're here, and we will, our agenda looks like this. So first, a very brief introduction to SmartSpeed AI, the acceleration techniques that enable SyntheticMR to really speed up their scans. And then Nico Höfkens from SyntheticMR will give you an introduction to what is SyntheticMR, scanning from SyMRI. And in the end, the star of the day is our KOL from Fondation Rothschild in Paris, Dr. Julien Savatovsky. He has been working with this tool for 8-9 months, and he will give you his initial experiences with this and also a perspective of how this will look in the future. Should you have any questions, you're very welcome to put them into the Q&A in the chat box, so you can ask questions in the chat, and we will come back to that later on in the presentation. But first of all, in Philips, we are very proud of our acceleration techniques. We have worked very long on improving it. It's always a matter of improving image quality and make sure that you can scan faster. Back in the last millennia, we developed what was called SENSE back then, normal parallel imaging, and then it went into digital coils. We did multiband sense, and then came like a real breakthrough a few years ago with compressed sense, where we use clever mathematics you call wavelet transform to really filter out a lot of the noise. And if you remove all the noise, there's a really good chance that you can scan a shorter time and still get a great image. And based on that, we worked with that for a number of years. Based on that, we said, okay, can we do it even better with AI? And so AI was inserted into the compressense technology, and the results were amazing. So one of the things, and I will not show images with compressense AI, but the key is really that you can scan faster if you want to do that and keep the image quality. You can scan at the same time slot and just get better images, or you can do something in between. But what really makes Philips' solution stand out is the wide compatibility. We can accelerate 97% of your normal everyday scans using compressense AI. And that is basically the foundation of what we are going to show you, is that now you can even accelerate quantitative imaging with AI. And that brings a lot of new possibilities. And that would be sort of what I want to talk to you about, because now Nico Höfkens will present to you the slides on what is the quantitative imaging that SmartQuant delivers to you. And so over to Nico.
Thank you, Ola, for the introduction. So at this point in time, SmartQuant is the only solution that actually allows quantitative MR with AI acceleration. Now, to go from SmartSpeed to SmartQuant, we need two more building blocks. We need actually SyMRI, and we need SyConnect to be added to that. So SyMRI gets input from a single proprietary MDME scan. Dr. Savatovsky will provide a bit more details on it later on, that in a fast acquisition, and then this would be typically 3 minutes with SmartSpeed, provide a combination of 8+ contrast-weighted images, as you see here, but equally quantitative data, including myelin volumes, but also tissue segmentations, volumetric data, and age-stratified reference curves, which actually allow you to check whether your patient is within a normal distribution for a given measurement. So aside quantification, SyMRI also allows you to really speed up your practice. Looking at the contrast you're seeing here, it would take you at least 15 minutes to acquire these conventionally. Now, with synthetic acquisition on its own, so the MDME sequence on its own, it's going to take you 5 to 6 minutes. With SmartSpeed, we can accomplish this, and Dr. Savatovsky has accomplished this in less than 3 minutes. So with that, fast generation of a lot of contrast obviously could lead easily to information overload. Getting all of this information onto your PACS in one go would lead to too much information. So with SyConnect, we have a solution that actually, as with a prescription for conventional imaging, you would give the information to SyConnect which images should be processed for which indications. And so you would get, as a clinical user, you would get these images directly onto your PACS workstation. You see here an example for an MS protocol or for a tumor protocol, but it could essentially be any set of images or quantified data that you would require. So in summary, with an acquisition of less than 3 minutes and a post-processing time of about 10 seconds, the requirements are on your PACS viewer before your patient leaves the scanner. And this process is completely, so the data remains completely on-premise. There is no data that is sent outside of the hospital. So with that, I want to hand over to Dr. Julien Savatovsky, who is the Deputy Head of Diagnostic Neuroradiology at the Fondation Rothschild, who will give you an insight on his clinical experience with SmartQuant over the last 8 months, and then how it has impacted his clinical workflow. And additionally, he will share his vision on what this technology will be able to bring in the future. So, Dr. Savatovsky, dear Julien, the floor is yours.
Thanks, Nico. So I will share with you now my experience on SmartQuant for the last month. So as it has been said, it's a fast quantitative MR that is integrated in our workflow now. Here are my disclosures, and I must disclose a research partnership with both SyntheticMR and Philips on SmartQuant. So all the images that you will see were acquired on an Ingenia Lesion 3T that was installed a few years ago, and that had an update to allow DLR reconstruction with SmartSpeed. And we use a patch that I will show you later to combine the SyntheticMR and the deep learning reconstruction. So we are a specialty hospital, so you will see mostly images from brain and CNS diseases. So the learning objectives of this will be that you will be able to demonstrate the utility of assessing multiple synthetic sequences that are taken from a single acquisition, and I will show you multiple examples so you can compare data sets that comes from real life example and comparing conventional and synthetic weighted images to see the equivalence of both data sets. We will briefly describe the zero-click workflow to produce the images, and we will see how we can assess the added value of quantitative maps and volumetric reports through clinical examples. And then we will take a few minutes to foresee the future additions of SmartQuant that are coming in the following month. So let's start up with showing several examples on how you can assess those sequences and hopefully trust the results that are given by those sequences. So here is a first clinical case of a 29-year-old male with diplopia. He had an MRI in an outside center on which we didn't find any cause on the diplopia, and he came back to us to try to solve it out. So here, one of the conventional data sets that we obtained at the level of the abnormalities, there were a single abnormality that is to be seen, and those are the conventional sequences with a 3D T1 TFE, proton density and T2 2D scan, and a 3D T2 flare scan, and we don't see much on this. We notice that as usual in 3T 2D sequences, we have quite a bunch of artifacts that are quite disturbing in the posterior fossa. Next, we will show a 2D MDME sequence that is what we are showing you today, that combines SmartSpeed and SyntheticMR multi-echo, multi-delay sequence. And with that, we can generate several synthetic weightings, including proton density and T2. And I'm showing you next to the conventional sequences in order to prove that you depict very well this lesion of the pons, both in the synthetic T2 flare sequence, the synthetic T2 sequence, and we can even do a synthetic SIR sequence or a synthetic double inversion recovery sequence. And we can demonstrate very well on all those synthetic weightings that we see a medial longitudinal fasciculus inflammatory lesion. As the patient had no further lesion, we cannot yet diagnose a multiple sclerosis, but it's a very typical location of inflammatory lesion, and it explains the diplopia. So with one single scan, we were able to obtain several synthetic weightings, T1, proton density, T2, flare, a double inversion recovery, phase-sensitive inversion recovery, and we could even take it to a further level and generate some custom weightings, such as this phase-sensitive double inversion recovery. So it's very convenient, and we can save as much as synthetic weightings that we need for one given clinical applications. And as Nico said, we also have myelin maps, segmentations of gray matter, of white matter, and CSF, which allows us to give you several volumes, which we will see later on this topic. So all this comes from one single sequence, that is a 2D multi-delay, multi-echo sequence. And I won't get into the details, but for each slice level, you get a matrix of 8 images with 2 echo times and 4 different inversion times. And with that, the SyntheticMR software will calculate several quantitative maps, R1, R2, and PD maps. And it's no IA processing, it's just a mathematical model. And from those 3 maps, you can generate basically any synthetic sequence that you need with those 2 formula. You can even choose and customize the TE, the TR, and the TI, or a second TI. With this formula, you will get the images that you want, and it's automatically done by the software. With all those maps, the software will be able to do a very reliable segmentation of anything that is needed. And from this segmentation, you will get the volumes, and including several useful parameters such as brain parenchymal fraction. So the workflow is very important with this software, and hopefully with SyntheticMR, the workflow doesn't require any additional click either for the technicians or for the radiologist. The images will automatically go through an on-premise server, and the on-premise server within usually less than 1 minute will generate everything, and it is you can set up what you need in terms of synthetic weightings, and then it will automatically send everything to the PACS. So when I open my case in the PACS, I don't need actually to do anything, and I will see the images that comes from the sequence in yellow here, and straight when I open the case, I will have all the synthetic weighted weightings that I have set up in the synthetic server for the lifetime of the server. And when I open the case, I see all these series, so I don't need to bother generating anything. It's always available without any click from the radiologist. So we can have several flavors of the MDME sequences, and we optimized 2 sequences, one that is high resolution and normal scan time that we use for MS and for brain tumors, for example, and another one that is very fast and that has regular spatial resolution and that we use in critical care cases. And this sequence is very interesting because in less than 2 minutes, you can actually have as much as weightings that you need and have various volumes. So now we will try to assess the added value of quantitative maps and volumetric reports, and we will take this occasion to see further examples of using synthetic weighted images. So here's a case of a 32-year-old female with MS. We follow up its MS, and she has no new symptoms, but she has marked fatigue. And this is to compare the regular T1 and T2 flare scan that we have with the synthetic T1 and synthetic flare. As you can see, most of the lesions that are visible in our regular dedicated 3D flare are still visible on the synthetic flare. But what I find interesting is that we see sometimes additional lesions, and we do not yet understand exactly why we see those additional lesions of MS that are not visible in the regular data sets, such as cortical lesion here. Or in this other slide, we see this cortical lesion that is better visible. And one of the things that makes it better visible is that we can have several additional weightings that we don't have in the conventional data set. I mean that the flare, the double inversion recovery and the PSER can be ordered at additional sequences, but it will take a lot of time. So in addition of those synthetic weightings, you will have several mappings that you can use for research, including R1 or T1 mapping and R2 or T2 mapping. And interestingly, with the automatic segmentation that is also done in 0-click, you can actually get several volumes that are specific to your patient. And our neurologists find it very useful because in this patient with a very low lesion load, they didn't understand why she had so many symptoms. And now that we can provide, without any additional research processing, the brain parenchymal fraction, and we can locate the patient among people of the same age, and we can see that the brain parenchymal fraction is reduced. It gives an additional insight to the neurologist to better understand the disease burden. So the DMS protocol with the 2D MDME sequence is pretty much similar as the one we used previously. We wanted to add no further scan time, so the scan times remains around 17 minutes, and we just replaced the actual PD and T2 that we have previously done with a 2D syntac. And the reason why we keep all the conventional sequences such as flare and 3D gradient echo T1 is that we additionally want 3D sequences to be done in order to optimize the comparison and if we need further analysis of the volume. But by doing this, we still have the PD and T2 weightings that are done in the synthetic way, and as you have seen, it is slightly of better quality of what we did with the conventional sequences. But what we like is that we have additional complementary synthetic weightings that doesn't require any additional acquisitions such as double inversion recovery and SIR, and we get those quantitative myelin maps and those reports that give us the brain parenchymal fraction, so without any additional time. So this is another example of a 26-year-old male with status epilepticus. So the conventional sequences are upwards, and as you can see, you have a mass within the right frontal lobe that involves both white and gray matter. It has no enhancement and no perfusion abnormalities, so we diagnose the diffuse low-grade glioma. And as you can see with the synthetic weightings, we don't have much additional information. Maybe we see a little more on the SIR sequence, the blurring between the gray matter and white matter in some areas where the involvement was not that clear on the FLAIR sequence, but basically it doesn't change our diagnostic. So what we have found interesting is that if we compare the conventional 3D FLAIR that we get and the synthetic T2 FLAIR, we see some slight abnormalities that were not seen on our conventional FLAIR sequence. And if you look closely at the synthetic T2 and the synthetic FLAIR, you see that areas with the arrows show a T2 FLAIR mismatch, which means the T2 signal is high and the FLAIR signal is low, and you can see it in other areas here. And actually the T2 FLAIR mismatch is a very important diagnostic clue in that case. And there are several articles that actually try to explain what is the T2 FLAIR mismatch and where it comes from. And actually you have this mismatch because you have both long T1 and long T2 relaxation time, and those couples of long T1 and T2 relaxation time seem to be specific of IDH mutant low-grade glioma. So actually you have an additional clues from those T1 and T2 maps that are given without any additional scan time, which tell you that it's likely an IDH mutant glioma. And further sequences that have been done in this patient shows indeed that the APT is not very high, which is a clue to diagnose an IDH mutant. And we have a slight peak on the MR spectroscopy at 2.2 ppm, which is IDH2 peak, that is hydroxyglutarate peak that is very specific to those IDH mutant gliomas. So we have a lot of additional information from one single scan that can easily replace any other conventional sequence. And the next example and the last example that I will have with 2D sequences is an acute optic neuritis in a gentleman with recent right-sided visual loss. Those are the conventional sequences with a almost 4 minutes T2 and a 4-minute T1 post-GAD with fat suppression. And this is what we get from a single 2D sequence that is tailored for optic nerve imaging with high resolution and thin slices in only 4.5 minutes. And we can clearly depict the high signal intensity of the right optic nerve in T2, but I find it even more visible in the synthetic proton density weightings and in the synthetic T2 STIR. So there is a lot of controversy on whether you should do T2, T2 STIR, and with SyntheticMR I can get all those sequences in one single acquisition, and I can even get the T1 weightings. For now we cannot activate fat suppression, but I believe it will come very soon. And you can also see the contrast enhancement in the T1 post-gadolinium, but also in the T1 mapping that is quantitative. So you can also get the T2 mapping and then have a sense of quantitative value that may have a prognostic value in those optic neuritis. So now that we have seen a couple of examples of 2D images and what the quantitative maps and volumetric report can bring, we will try to foresee the future editions of SmartQuant, and we will spend a few times on this because it's not yet clinical, but it will soon be, and I find that it will really be a huge step forward. So the first thing which I find very important is that now we have ability for research of doing 3D sequences that are usable with SyntheticMR. So we can have in research for now, but it will soon be on the clinical practice side, a 3D sequence on which we can do isotropic voxels and reformat in every plane. And those sequences will, as the 2D examples that I have showed you, be able to generate several synthetic weightings. So this is an example of a 34-year-old female with MS, and those are the conventional data sets for you to compare and for you to see that we do not lose any MS lesion with the synthetic weightings, and additional to the regular weightings that can now replace all the regular conventional sequence. You have all those additional weightings, 3D proton density, 3D T2, 3D PSR, and 3D double inversion recovery. And we can hopefully reformat this in every plane for each synthetic weighting. So it's like that you have done 6 different 3D acquisitions and be able to see them and to help you confirm whether the MS lesion is there or not. And you can absolutely reformat it in every plane. So this is an example of a subtle subcortical T2 lesion that is very well depicted on the synthetic T2 flare. That is better visible on the double inversion recovery and the PSR, that are not additional sequences, but just complementary to use with the single 3D CALAS acquisition. So now that we have this 3D multi-contrast sequence, we can really go a step forward. I have shown you that the MS protocol that we used with 2D SmartQuant was pretty much the same scan time that we used before, but now that we have it on 3D, it gives us the possibility not only to remove the 2D PD and T2 sequence, but also to remove the T1 gradient T-co sequence and also the 3D flare sequence, and all of that will be replaced by a single 4-minute sequence that is 3D, that can be used for reformats, and on which you will have all the sequences that you need and that you can now remove from your standard protocol. So now the important thing is you have all those complementary sequences that are on green, but you also can reduce the scan time because you will replace 3 sequences by only 1 sequence that has almost the same acquisition time. So of course, what it will not do is replace non-conventional sequence. And in our MS protocol, we kept, for example, the 3D susceptibility EPI sequence that helps us assess the central vein sign, for example. And we also kept the diffusion weighted sequence that cannot be given by synthetic weightings from the CALAS sequence. But it's already a lot of improvement, because when you go from a 17 minutes time slot to a 12 minutes time slot, then in an hour you can scan 1 patient more. So here is another example of patient to show you a variation of the sequence that is faster and that we use, for example, for meningioma follow-ups. And this is a sequence that is not quite isotropic. The reformats and interpolation makes it isotropic, but we gain a little time by doing it with a 2 millimeter thickness. And this is an example to display that the contrast that we obtain with the synthetic weighting is very good. In the upper line, you have the conventional weightings, and we have done it with the full gadolinium dose, but in the middle, we have done it with 1/6 of a dose, so a very low dose of gadolinium. And as you can see, with the SyntheticMR generated images, we get a very good contrast, even with low injected dose of gadolinium. And those are the actual slices on which you see that with the full dose, the meningioma is very well depicted, but with the reduced dose, it is still very well visible, and it's not inferior to the conventional T1 post-gadolinium. So the final example with this 3D multi-contrast sequence is that we have given a try on the cervical spinal cord anatomy, and it's still research, but we get very good results. And this is the comparison in an MS patient between the conventional T2, the synthetic T2, the conventional T1 plus GAD, and the synthetic T1. So basically, those two images comes from the same acquisition, so obviously it will be a gain of time if we can use that strategy in every patient. And you can see that the high signal intensity lesion here is very well visible, and that you can demonstrate on the synthetic T1 post-gadolinium that it enhances as well as in the conventional T1 sequence. And you have several other lesions in order for you to see that you can depict it very well on the synthetic weighted sequences. And the nice thing about this sequence is that as it's 3D, you can also reformat it in any plane, and I can retrospectively choose the level to do my actual slices. I don't need to order the technician any additional actual sequences, and you can see pretty much very well on these actual reformats that you can see the T2 high signal intensity lesion. You can see which part is enhancing and which part is not enhancing, and you can see it even if it's on the side of the spinal cord, which makes it usually less visible on the sagittal slices. So it's very useful. Within one sequence, we can have both T1, T2, and additional weightings and reformats. So here's one example to display that the 3D sequences also have the quantitative capabilities. This is a 67-year-old female with gait disturbance, and you can see that she has hydrocephalus. You can see the actual synthetic weightings and the sagittal reformats. As you can see, it's an isotropic voxel that can be reformatted in any place. So basically, in one single sequence, I get everything that I need to assess both parenchyma and ventricles, and I will get for free all those segmentations and additional myelin maps. And which is very interesting in hydrocephalus is that I will have the CSF volumes quantifications. And as you can see in this patient, we have a very high CSF volume. And an additional information that we were not aware of in this patient is that the intracranial volume is also raised. So she has microcephaly, and it was a clue to diagnose long-standing ventriculomegaly in adult. So to conclude, we now have the ability to generate multiple synthetic weighted images from a single sequence. So both with 2D and soon with 3D sequences, we can, by using SmartQuant, generate as much as synthetic weightings that you need for one given clinical application, and it is customizable which synthetic weightings you will obtain. It's a zero-click workflow to produce the images, both for the technologist. Once you have acquired the sequence, it will go through the server and go directly to the PACS. And so when the radiologist open the case in the PACS, he will get all the synthetic weightings and quantitative maps that he wants to have. So this gives us the potential to have a great gain of time in our acquisition protocol, which means less time in the device for the patient, so more comfort, but for us also the ability to scan more patients a day, which is quite important given the pressure of doing a lot of exams to raise more money with the lower income that we have per exam. With that same acquisition, we can have the added value of quantitative maps and volumetric reports. And I hope with my examples that you are convinced that it's a real added value in some clinical indications. So I'm open for questions, and I thank you for your attention.